Hello students, myself Dr. Maddineni Srinivas, your dermatology faculty in Cerebellum Academy. We are going to see the previous year questions of FMGE June 2021 in this video. So this is the first question. A 40-year-old man comes with the complaints of hair loss. So the complaints are hair loss. Examination findings are shown below, where you are able to see there are multiple patches of hair loss, and it is mentioned that swarm of bees appearance is seen on histopathology. The most likely diagnosis in this man is, and if you have marked the answer as option A, alopecia areata, absolutely correct. So please remember, whenever you get a image which is showing patches of alopecia which are absolutely non-inflamed. What do we mean by non-inflamed? That is, there are no papules, no pustules, no erythema, no scaling. And you are able to see that in the patch of the hair loss, there is complete loss of hair. So if you get to see this clinical picture along with the swarm of bees appearance, so which simply means that in alopecia areata, what happens in a given hair follicle, there are going to be lymphocytes. There are going to be lymphocytes surrounding the hair bulb, which appear like a group of bees. That is the reason why histopath of alopecia areata is described as swarm of bees appearance. So the most likely diagnosis here is option A, alopecia areata. So if option B has to be the answer, the examiner would have mentioned a child coming with a boggy swelling over the scalp with associated regional lymphadenopathy, and easy pluckability of the hair. Easy pluckability of the hair. Whereas in trichotillomania, please remember the question is going to mention mostly a female who is having some psychiatric disorder, most likely obsessive compulsive disorder can be mentioned. There is also going to be a mention that it is incomplete hair loss in a given patch, and also hairs of varying length can be noted. Hairs of varying length. And on histopathology, we are going to see important perifollicular hemorrhages. Perifollicular hemorrhages can be seen. And in the case of androgenetic alopecia, it is going to be male pattern showing frontotemporal hairline recession. Frontotemporal hairline recession. This is the next question. A 30-year-old female presents with lacy lesions in the oral cavity and genitals. A proximal nail fold has extended onto the nail bed. What is the most likely diagnosis? So this lacy lesions in the oral cavity and the genitalia are Wickham's striae. And this description of proximal nail fold extending onto the nail bed simply means the examiner is trying to explain or describe about pterygium. So Wickham's striae and pterygium are seen in option D, lichen planus. So this is how the lacy lesions will look clinically, and this is the proximal nail fold which is damaging the nail plate and it is attaching itself onto the nail bed. So it is destroying the nail plate and attaching onto the nail bed, forming a wing-shaped structure. This is the next question. A 22-year-old college student presents with small depigmented lesions which have been present for a period of 2 years. So what is the most likely diagnosis? And in the image, if you see, yes, there are depigmented lesions which are present. There are depigmented lesions which are present, and the time duration is for over a period of 2 years. That means this depigmented lesions have developed in an adult. So we can say it is an acquired depigmented disorder in which vitiligo is the diagnosis you should always think about. So what are the other options? The melasma, it is going to manifest with hyperpigmented macules and patches over face. Whereas here lesions are present over the body and that too they are depigmented. In psoriasis, what are the lesions which you are going to see? There will be erythematous, silvery white plaques present mainly over the extensor aspects. Coming to dermatitis herpetiformis, so this is a vesiculobullous disorder. To be precise, it is a subepidermal blistering disorder. Subepidermal blistering disorder in which patients are going to present with vesicles and excoriation marks over extensors. So this is going to be the description of the other three options. And the next question says painless lesions present over the vulval area. And in the vulva, if you observe carefully, there are warty lesions which are present. So if you get to see this kind of warty or rough surface lesion, always remember the answer is going to be condyloma acuminata. So please remember the genital herpes is going to present with grouped vesicles present over the genitalia, which you are able to see when these ulcers rupture. They are going to leave behind polycyclic erosions. They are going to leave behind polycyclic erosions. And in this picture, you are able to see that there are moist, broad based papules which are present. So these are characteristically seen in condyloma lata, which are mucus lesions seen in secondary syphilis. Mucus lesions which are seen in secondary syphilis. Okay, very, very important to remember. So the next question says the farmer comes to skin OPD with a painful swollen foot which has discharging sinuses, and there are dark grains coming out of the sinuses. Gram stain was negative. Which of the following is the most probable diagnosis? So you are able to say yes, that there is swelling, there are sinuses from which granules are coming out. So with the GST, you all already know that it is a mycetoma. But here in this question, the examiner is asking which type of mycetoma, because in the options we have eumycetoma as well as actinomycetoma. So what are the additional clues given apart from the GST? Dark grains is mentioned, and also it is given that gram stain was negative. So if gram stain is negative, then you should think of the fungal cause of mycetoma, which is eumycetoma. So please remember, in eumycetoma, gram stain will be negative, and also remember the grains are going to be dark in color. Dark grains will be present. So in the case of actinomycetoma, gram positivity can be seen and pale granules or grains will be positive. So here what will be the answer? It is going to be U mycetoma. It is going to be U mycetoma. And this is a case of sporotrichosis, which was there in the option. Sporotrichosis is produced by Sporothrix shinki. Sporothrix shinki, and this is going to manifest with nodulo ulcerative lesions in a sporotrichoid pattern. In a sporotrichoid pattern, which means along lymphatics. Along the lymphatics. This is the next question. A lady developed painless beefy red genital ulcer with swelling in the inguinal area. On biopsy, safety pin appearance was noted. So which of the following is the most probable diagnosis? So this description of beefy red genital ulcer is very characteristic of donovanosis, which is also called as granuloma inguinal. The answer is option A. So there is a mention that swelling in the inguinal area is noted. But please remember, in donovanosis, there is no inguinal lymphadenopathy. So this swelling in the inguinal lymph area is called as pseudobubo. Pseudobubo. And let us see what are the other options and their characteristics. In LGV, you must remember the patients are not going to notice the genital ulcer. So genital ulcer goes unnoticed, is gone unnoticed. Whereas in the case of syphilis, the patients are going to present with painless genital ulcer and painless inguinal lymphadenopathy. In the Shankroid, what are we going to see? In Shankroid, we are going to see a painful genital ulcers. Why? Because there will be multiple ulcers present, and also the inguinal lymphadenopathy. The lymphadenopathy is going to be painful, and it is specifically called as a bubo. So this is how the description of the other STDs will be. And coming to the description which was mentioned in the question, so you are able to see these safety pin appearance of the safety pin appearance of these organisms which are seen in donovanosis, This is due to the bipolar chromatin condensation which occurs. Bipolar chromatin condensation which occurs, and these are going to be present in the macrophages. So the macrophages along with this Donovan bodies, both of them put together, we call them as Pund cells. We call them as Pund cells, and these are of course Donovan bodies.